welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is March 5, 2021. I'm Jeff Lassers, and I'll be your host. This episode was recorded on February 12, 2021. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. This is a 4-part series focusing on EMS patient care reports, or PCRs. This series has been developed in collaboration with the Oakland County Medical Control Authority, or OCMCA, and various EMS providers as a way of providing information and guidance to EMS agencies and personnel. Although we reference the OCMCA and our local and state EMS protocols, this series is beneficial to all EMS agencies and providers. Like most EMS systems, the Oakland County Med Control focuses on quality assurance and/or quality improvement programs with a patient-centered approach. To facilitate this process, the OCMCA develops and disseminates required education to its EMS providers as one aspect of their annual EMS Quality Improvement Program, or EQIP. Since 2015, EQIP has provided a uniform, standardized, systematic, and responsible quality improvement program through education and OCMCA support. EQIP can be broken down into 3 primary components that all OCMCA EMS agencies are responsible. These include required data reporting, required education, and measurement of protocol knowledge through assessments. In 2021, all OCMCA EMS agencies are responsible for assuring that all of their EMS providers complete this 4-part series or cover the same learning objectives with their personnel. All of the details regarding the 2021 EQIP requirements can be found at ocmca.org/EQIP. EQIP. That's ocmca.org/EQIP. Again, even though this series was developed specifically for EMS providers in Oakland County, Michigan, it certainly applies to EMS on the national and even the global scale. It is impossible to cover every detail, aspect, and nuance of an EMS patient care report. However, we hope that EMS providers and agencies use this podcast series as a way to start a conversation and/or train on producing quality PCRs that consistently show an understanding of current protocol knowledge as well as patient-centered decision-making in the field. Throughout this series, you'll hear from a core group with a vast amount of experience and knowledge. Everyone that appears in this podcast series has significant experience with EMS education, QA/QI programs, as well as EMS agency and system administration. Joining us in today's discussion, we have Bonnie Kincaid, who is the OCMCA Executive Director. We are also lucky enough to have Emily Bergquist here with us, who is the current State of Michigan MCA Coordinator, as well as a longtime Paramedic and EMS Instructor Coordinator. We are also joined by Emily Baker, who is currently the EMS Coordinator at Ascension Providence Hospital in Southfield, Michigan, as well as the CQI Supervisor for Alliance Mobile Health, which is a private EMS agency in Oakland County, Michigan. And finally, last but not least, we're joined by my friend John Thoit, a longtime firefighter paramedic and EMS Instructor Coordinator who is the new OCMCA Quality Improvement Coordinator, as well as a shift captain and the EMS Coordinator for the Ferndale Fire Department, located in Oakland County, Michigan. You can find our guests' contact information in the episode description. In this episode, we'll discuss the value of EMS patient care reports. Primarily, our goal is to increase EMS's appreciation and awareness of the value and relevance of EMS patient care documentation, as well as how to implement best practices into their work. To accomplish this goal, our guests will help us appreciate the value of consistency and quality when drafting an EMS PCR. Then, we'll list and describe the benefits experienced by patients, EMS providers, EMS agencies or systems, and hospitals regarding consistency and quality when drafting these PCRs. And finally, we'll describe the current data and trends identified in PCR quality assurance and quality improvement initiatives found throughout Michigan and the U.S. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. I really can't ask you guys this enough. Please leave us a rating and a review and help us get noticed on a much larger scale. Remember, the mission of the EMS On Air podcast is to keep healthcare providers safe, informed, and prepared. So, increasing our ratings and our reviews gets us noticed by more listeners and more sponsors that will lead to increasing our reach, resources, experts, and abilities. Bottom line, ratings and reviews are currency in 2021. It is vital to our growth, and your contribution will give us what we need to serve those that serve our communities. The only cost to you is a few minutes giving us a rating and a review on whatever podcast platform you use. We're available on every podcast platform that you can think of, so it's super quick and easy. Thank you, and enjoy the podcast. Good afternoon, everybody. How are we?
Wonderful.
Fantastic. Wow.
Great.
Awesome. Well, we are here with a whole bunch of people, as we said in the introduction, and really what we're getting after today is the OCMCA EMS Quality Improvement Program. So, Emily, can you kind of dive into helping us appreciate the value of consistency and quality when drafting an EMS patient care report, and specifically from your role, that professionalism in EMS and the role of that EPCR?
No problem. Thanks, Jeff, for having me. The first thing I kind of want to talk about is the tie between professionalism and documentation or patient care reports. We want, as the EMS, to be considered professionals. We want to be considered a part of the healthcare system, and part of that is taking that into account with our documentation. In the time that I've been in EMS, there's been a lot of growth with EMS and what we are allowed to do and who we interact with. And we have to realize that our documentation and the report that we create is looked at in a lot of different ways. The first thing that we kind of have to talk about is completeness. A lot of our vendors, well, all of our vendors, I think, in the state of Michigan, where you would put in your documentation. So there's, I think, 15 of them in Michigan, but across the country, there's even more. They all give you some sort of a completeness score when you're doing your documentation. So I challenge you to kind of pay attention to that as you're doing your report, because it's not tracking that for no reason. So that completeness score is variable depending on the type of report that you're creating. So someone will say, well, Emily, it always wants me to give a patient contact time, but I can't give that because I didn't have a patient. That's not exactly true. The softwares are relatively intelligent. And if you change your disposition to no patient contact, it will not ask you for that time anymore, and your completeness score will increase. So I encourage you to pay attention to that and spend some time. I know nobody has a lot of time actually looking at it. So it's not the same standard across every report, but it's really important that all of the pertinent stuff is filled out so that the run is complete. It's an entire record. So the second piece is that it has to include everything about the incident. So this is special to EMS. If you think about other places in the healthcare system, for example, a doctor only reports about their specific things that they see in their assessment piece or their treatment piece, and a nurse documents one way and a tech documents another way. EMS is special in the fact, and also I would say more difficult, because you have to document everything. You have to document all of the things, the entire incident, where you found them, how you moved them, what you did with them. All of those things one person documents as opposed to a whole bunch of different people documenting. So if things are missing from the report, it can kind of look really one of two ways. One is you didn't do it, right? So not documented, not done. You're absent-minded, which doesn't really reflect very well. I guess it's three ways. And then the third way is that it was an intentional oversight. So you didn't put it in there because you were trying to hide something. So make sure that your EPCR is complete and includes everything from the incident. Spelling and grammar, I've heard a lot of people talk about how it shouldn't count because it doesn't actually reflect on their patient care. And while that is true, you can be a great paramedic and not spell very well. It does reflect on your professionalism. If, for example, I can't spell epinephrine correctly, do you think that people are going to believe that I know everything that I need to know about epinephrine in my report? So make sure you're paying attention. And this is actually a gift that EPCRs is giving us.
It just seems like ridiculous that you can't spell correctly when everybody's pretty much using a computer these days or some type of technological device that usually has an autocorrect function.
Yes, it's not perfect.
No,
Emily.
no, but they seem to be improving with their ability to do medical terminology. And then in addition, there's all these websites where you can literally copy and paste a paragraph into something to assure your grammar was at least okay.
One thing that does need to be considered, if I may interject, is that some blockers that different companies use to protect their devices may disable features like that. So that's something that at the agency level, we need to consider to support our EMS providers in their documentation.
Yeah, that's a really good point. For like Jeff was referring to, there's more than one website where you can do that. And some of the software vendors actually have some of the autocorrect features getting better and better as the things go on. And thinking about it, that's one of the really great things about electronic documentation. We didn't have that before. When we had paper charts and they were 4 carbon copies deep, and you'd write a whole sentence and then realize it was wrong. It was a very sad time. At least we have a delete key now. But just read through your report and make sure it makes sense. Make sure it says what you actually meant it to say, because grammar does matter. Commas really matter when you're trying to depict different things. The next one is about the continuum of care and about documentation. It is real that people in the hospital will go back and look at it, and people like primary care physicians can read that report a week later, for example. Like, what exactly happened? We've had, when I worked at an agency, like cardiology offices, patient status post cardiac arrest, they had a cath. Now they're having follow-up with their cardiologist, and their cardiologist wants to see the report about the incident that happened. And, this is weeks down the road. Somebody is actually going back and looking at EMS and saying, what was the heart actually doing? What was the incident like? So that they can understand and treat their patients forever down the road based on what you saw at the time of the incident. So pay attention to the fact that there are going to be other people looking at your report. It's not just you. It's you, it's your supervisors, it's the patient, right? It's their record. They could pick it up and read it.
I was in that situation, actually. I was the patient, and in about 2010, it was like 105 degrees outside where I was, and I must not have been hydrated enough, and I had a syncopal episode. I just went out, fell over, hit my head on the ground, and I woke up in the back of an ambulance. Well, here we are 11 years later. I had a Zoom appointment with my primary care physician just to do that checkup. It's nice. They let you do that now. And she's like, oh, it says here you passed out one time. I'm like, what are you looking at? She's like, oh, your records. She was reading the narrative from the EMS patient care report from that agency. So even my primary care physician got to see the eyes and ears of that person who was looking at me, who had this weird just passed out and hit his head.
Yeah. And I mean, there's a lot that they can infer, not just about your incident, but about the whole EMS community by what they see. So if they're looking at records and it's poorly documented, they don't understand what actually happened, and it doesn't really make sense. They're going to think EMS is not professional. They're not paying attention to what's going on with the patient beyond their little incident. And they can make some pretty broad generalizations about how they want to include us in the system. So it just keep that in mind about how it's going to help your patient, and also how it's going to help our entire profession move forward. And then the last thing I have about this is about legal compliance and record keeping. And I don't like to dive too far into this because these are laws that aren't really from our office, but all the records do have to be kept. They are legal documents and part of the patient's medical record. They have to be kept for 7 years or 7 years past when the patient turns 18. So like a baby's record, for example, would be kept for 25 years because that is what the medical record law states has to be done. So keep that in mind. Somebody asked me the one day about what about if we do it paper first and then move it to electronic? Can we just destroy it? And I was like, well, how about you scan it and attach it? Because can you really copy that over 100% exactly the same? Because I would guess the answer to that is probably not. So the best practice for that is scan it and attach it. We are in the year 2021. We have scanners. We have wireless scanners. There's all sorts of things that we can do to scan it and attach it to the record. And then the last thing I just want to talk about is Hippa and high tech, which are the technology and privacy laws. Those are federal laws. And you can be criminally prosecuted if you don't take care of these records the way that you should. and that goes for individuals and agencies. I think about at times in my career, because we're all humans, right? I would get a face sheet from the hospital and I'd set it on the dashboard of my ambulance. Like, oh, maybe you should pay attention to what you're doing and you shouldn't do that. Or they would stick them in like the map holder between the seats, and then patient family would ride in the front and other patients' records were sitting right there. We do a lot of really, or have done a lot of really questionable things. Like I said, I don't throw anybody else under the bus. It's my bus too. So keep that in mind. Think about it. Have some sort of a secure folder or place where you can put things if you have to have paper records, and always keep your laptop secure. Lock it up. Don't put it places where other people can see it. So that's kind of like the professionalism pieces.
Would you say that locking up that laptop, so we use an iPad, it's password protected? Good enough?
It's good enough if you're going to have it with you. Or
oh yeah, it never leaves my side. It never leaves our side. It's never out of sight, and it's in a locked ambulance when we're not in it.
That's what the correct answer is, right?
That's actually what we do. Where does it go? It's next to me.
Right, but I think about like, this is the best practices, right? Don't leave it in the EMS room when you go to the bathroom.
Okay, so you must have that thing secured at all times.
Yeah.
Copy.
Emily, would another good practice be not to have the tablet or computer remember your password?
I hope agencies turn off that function. Yeah, that would be a great idea. Do not have a computer remember your password. You know, different computers have different capabilities. Like my state computer, for example, I always joke around that we're the single most technologically advanced and secure place on earth. It will not remember any of our passwords. And that is how our IT people set it up. You have to log into everything. And anytime, for example, I'm logging into my EMS, I have to do a 2-factor authentication every single time because there's patient stuff in there. My computer, to log into it, I have 3 passwords to get it to turn on, and then every individual software inside of it has more. So I don't know that there is such a thing as too secure. So be the steward that you should be. This is other people's information that you're being trusted with.
To make a really clear expectation, you are accountable for that device and all of its information in it, and it's up to you and your agency to secure it. However you need to do that. Yeah,
and it's all of the things. If somebody uses your email to transmit something, even if you didn't do it, you're still accountable for it. So this goes across your patient care records, your emails, your laptop, whatever the case is, you're responsible for the things that are your logins.
Okay, fantastic. Let's move on to listing and describing some of the benefits experienced by our patients, our EMS providers, and our agencies, and even our system and hospitals regarding consistency and quality when drafting EMS patient care reports. Number one, again, it's all about the patient. For me, it's all about better patient care. You know, when you draft a quality report, to me, it's the third piece of communication when I'm discussing a patient with a hospital. Number one is my hospital pre-notification, contacting the ED. This is what I got and what I'm bringing to you. Number two is my face-to-face with the receiving facility personnel. Hi, this is our patient. Here's what's going on with our patient. And the third one is the legacy of that information that I leave behind. It's not good enough to just tell people what you had, what you did, and who you brought to them. You have to leave the information that helps them make decisions when you leave. And the person you gave that information to might not be the same person who's making decisions an hour from now and needs to see that piece of paper. And all of that, when done correctly, only leads to better outcomes, not only for the patient, but for reimbursement for the agency, for understanding communication between EMS and the hospital. Everything gets better. Emily Baker, why don't you talk about some of those benefits as well?
So the EMS providers, I don't think always think about how far their documentation truly goes and how much it can do for them as well as their patients. It's been touched on several times already that the EMS reports are read by several people in the hospital. They are used significantly within the hospital, and they can improve the working relationships that EMS has with the hospital staff. And we'll come back to that when we talk about the hospitals a little bit more and the use of the PCRs there. But one thing that Emily Berquist touched on that I think is incredibly important is the effect that a PCR and your documentation can have on your professional image. When I'm teaching classes on documentation, I like to take a PCR that has been scrubbed of PHI and put it up on the largest screen that I have available in the room and encourage everybody to imagine the last report that they wrote being on that PCR. And what would that look like to someone who doesn't know them? Is it whether it's a group of doctors that is making decisions about a protocol and if EMS is capable of carrying these additional medications and controlling them properly or performing these complex assessments? Or is it an attorney that is looking at that and making a decision about the competency of the EMS provider that was involved in a situation? That is the first impression that people get when they are evaluating a situation that an EMS provider was involved in, because the first thing they do is pull the supporting documentation. So ensuring that you're using professional language, checking your spelling is incredibly important. Another thing that we always want is the PCR to stand on its own. And that's really going to be something that saves time and headaches for our EMS providers. If I'm in a quality improvement situation and I'm reading a PCR, I should not have to ask questions. I should not have to call the EMS provider and ask them what was going on at the scene. It should stand on its own entirely. We don't want to go to court to testify about the blood draw that we performed in the jail. The document that we completed should give all of the information and answer the potential questions.
Thank you, Emily. Emily Bergquist, can you kind of touch on more from the system perspective and the agencies? Again, you're the Medical Control Authority Coordinator for the state of Michigan. That's something specific to Michigan, but you deal with every EMS system in Michigan. So kind of give us your take on that perspective from the agency and system.
So we have kind of beat around the bush with this whole better data improves patient care thing a couple of times already, and I cannot say it enough. People want EMS, well, all EMS providers, I think, want to be the most progressive, most awesome, doing the coolest things. Like, this is EMS, right? And without data, that cannot happen, because that is how we know what is or is not working. When people are like, oh, the state office is going to take this away from us, and it's the best thing ever. Well, if it's the best thing ever, we should be able to pull it up in a system, aggregate, and say, look at this. Every time we give this medication, we see an improvement in our patients. So if you are not documenting every time you give that medication, what happens to the patient? What are we basing it on? You know, one time Jeff told me a cool story about how this medicine worked for his patient. That's an anecdote or something that we've always believed that may or may not be true. So our documentation on an aggregate level is very, very powerful, because I can say the average statewide time for a chest pain patient to an aspirin administration is this many minutes. So we can actually know, not that Jeff is good or bad, but we are good or bad as an entire system of a medical control authority in a geography or as the whole state. So it really does matter. When we talk about quality improvement and being able to do better things for our patients, that is if you've heard of this before, the Plan, Do, Study, Act. So we plan for something, we come up with an idea, we recreate this new protocol, we implement it, we go forward, and then we look at what changed. So is doing 12 leads getting people to cath labs faster? We know the answer is yes, because we have data to go back and look and say, yes, EMS people having the ability to do this, to be able to look, that helps.
I think it's important to say right now that the current only point of entry, an opportunity for that information to enter the data stream, is at the EPCR level, input by the provider. It's not like you are one of a few people talking about this specific incident with this patient before they got to the hospital. It's the only one. And that data is only going to increase the value of what's going on in your community and the surrounding communities. Because again, you're probably going to go looking for things like grant money, and you're going to need that data. You're probably going to go looking for things like, hey, I want to change this protocol. Why? Well, I have all this data to support it. Great. Sounds good. Without that information, everything else is just an idea. An idea without a plan and data is a wish.
Yeah, it's not that nothing will ever change. It's just that things will not change in the correct way or in a scientifically driven way. And I can tell you that there are a lot of things inside our office that weren't always done in an evidence-based way. And we're really working for that. And we need people to put their information into the system so we can continue to do that. That's my spiel about how better data helps patient care, because without it, we're just saying, well, in Alaska it worked, so maybe it will work everywhere. We know that that's not the case. That's why our Michigan stuff is important. And then the other piece, this is kind of more agency and MCA driven. The legal protections around quality improvement in the state of Michigan are actually quite good if it's done correctly. I'm not an attorney, and I don't want you to think that this is like legal advice, et cetera, et cetera.
Yeah, give some context here for those that don't understand, which you're kind of referring to something that's really cool that a lot of people don't kind of understand. So a little background here as well, please.
In our statute in the state of Michigan, the agencies have a suggestion to operate quality improvement programs. So in Michigan, we have something called professional standards review organizations for quality improvement. And what those are review entities that can look at things that are protected. When something is reviewed inside that PSRO, they don't have to share that information with anyone else. That information is protected from the Freedom of Information Act, things like that. So it's kind of a safe space to talk about the hard subjects, to say, oh, this didn't go very well, or this medication isn't really working for us, or our response times are terrible, or, fill in the blank. It's a safe space for that to be done, but it only is protected if it's done correctly. If you're only looking at patient care reports when somebody complains about it, it's no longer protected, right? You have to have an actual quality improvement program where you're looking at things sort of proactively to try to figure out where things are wrong in order to have that protection. So it's not a reactive thing. It's a proactive thing that provides a protection for your agency, your providers, and your medical control authority.
Thank you for that. Now, I want to round out this part of understanding this from the hospital perspective. Now, Emily Baker, you currently work for Ascension Providence Hospitals in Southfield, Michigan. You're the ED coordinator there. You interface with EMS, and you have worked in the field for quite a long time as well. Give us your take on benefits being experienced by the hospital and why it's so important.
Well, I think the first thing that we're all a little aware of, but may not understand the full scope of, is continuity of care and informed patient care. As the ER provider, whether you are the tech, the nurse, the physician, if you have a question about what happened before you got here, before the patient got there, referencing the EMS PCR is the best source of accurate information. And that happens all throughout the patient's hospital stay. It is not as simple as the PCR arrives at the ER and it's read by the patient's nurse and maybe the physician that sees them in the ER. It is definitely not just, and this is my experience in multiple health systems, it is definitely not just put on the chart and forgotten about. The EMS PCR will follow that patient all through their hospital stay and be reviewed by several people. If a nurse has a question about the event that led to their hospital stay, when a consult is done by a different specialty and they want further information about the history of the present illness, even when pharmacy does their med rec and reviews all of the patient's medications, if EMS properly entered a list of all of the medications they found in the patient's home, they may find issues with the patient's home medications. They may find interactions that are not desirable due to multiple providers prescribing. So there is value every step of the way, and it can all improve the care that that patient is given. Another very big part that we've all referenced several times is the working relationship between the hospital and EMS. As I said before regarding professional image, the PCR is the first impression that a lot of providers get of the EMS provider. So reading that and having an understanding of what they did and how they did it and how competently they performed in the field is very important. This also follows the patient through to the quality improvement process on the hospital side. So even after that patient is discharged, the trauma team or the stroke team is reviewing the EMS documentation as a part of their audits. They will then discuss things with the EMS coordinator or an ED manager or whoever is the liaison with EMS and work to help provide further education and quality improvement for the EMS providers as well. So it can help drive integration of the pre-hospital environment and the hospital environment.
Thank you. This quick commercial break is brought to you by our educational partners, American CME. AmericanCME.com is an online continuing education learning platform designed for EMS providers by EMS providers. Their mission is simple: create and host high-quality video-based EMS CE content with the aim of improving the quality of EMS care while drastically reducing or eliminating the cost associated with EMS training. American CME courses focus on the most current topics and science related to the EMS industry and are available in a format that makes them convenient to access and complete. Over the last year, the EMS On Air podcast has teamed up with American CME to host many of our episodes on AmericanCME.com. This means that EMS providers can earn EMS continuing education credits by completing an entire podcast episode, a brief post-course quiz, and a survey. To do this, visit AmericanCME.com, click on the courses link, then click on free courses. Scroll through the course list and look for the courses with the EMS On Air podcast logo. Currently, there are 22 different EMS On Air podcast episodes hosted by AmericanCME.com, including the episode you're listening to right now, that are approved for continuing education credits for EMS providers in Michigan. But don't worry, we're working on getting our episodes approved in all 50 states and CAPCE accredited. And we'll be releasing another batch of episodes sometime in May 2021. Get on over to AmericanCME.com and get you some credits. Think about it: kicking back and engaged in an EMS On Air podcast episode and earning CEs. Come on, does it get any better than that for EMS continuing ed? Did I mention that you can access all of American CME's content for free? Yeah, free. And now back to the show. Emily Berquist, you mentioned earlier how pretty much every EPCR conveys a lot of data that gets added to this aggregate pile that can be used to make decisions. Can you give us examples by describing current data and trends identified in these PCRs that you're using in QA/QI initiatives throughout the state of Michigan and the U.S.?
I think that it's important to note that right now our data is being utilized more than it ever has. And part of it is because of, I'm going to give kind of two places where our data has become kind of invaluable around not just our state, but our country and really the world. One is around the coronavirus response, which I'll touch on a little bit more. And the other one is around the opioid epidemic. And the reason why it's so important is because EMS sees things that nobody else sees. And our data is so close to real time. And I always say, well, there's like an 8-hour lag or so before we can feel like some records are really in the system. And anytime we say that, I feel like the people who look at hospital data almost fall out of their chairs because everything else is so significantly delayed. So around coronavirus specifically, we do what's called a syndromic surveillance around this particular set of signs and symptoms that we would see with a COVID emergency patient. So respiratory problems, fevers, loss of taste and smell, et cetera, et cetera, et cetera. And when we look for it, we're looking inside the PCRs. We're looking at the narratives. We're looking at the signs and symptoms that are documented, chief complaints, all of those places. Oh, I forgot vital signs. We look at vital signs too to see about hypoxia and fevers, et cetera. So we look at all of those places to find patients who meet the description of a coronavirus patient, which, if you think about it, it's kind of amazing because we aren't waiting for the lab results. We're seeing it long before anybody else would. So we already know aggregate that there's an increase in a place in the state of these patients who look like coronavirus patients a whole day before we can know that they actually are coronavirus patients. And I did send in my notes, and I know that in the recording part, it won't really matter, but there is a picture that I shared of coronavirus patients by syndrome definition over the last year from March 1st through today, February 12th. And what's really interesting is when a syndrome is applied, we look backwards too. So we go back to look at it. And you can see that we didn't have any before we actually had patients. And I think that this kind of speaks to how good EMS actually is. We rag on our people pretty bad. We give you a hard time about it because we're trying to get you to be better. But our cases in EMS data wouldn't look like this if you weren't doing a good job. So the curves that we're seeing statewide of actual cases, laboratory confirmed cases, actually matches our EMS curve. So that's how good you are doing at documenting these patients, is that we can see this. We can watch for things happening. And this goes for coronavirus, and this goes for overdoses. This goes for car accidents. Like, is there an intersection that's actually really bad or not? It's a crazy heavy thing to think about, but we have millions, literally millions of records that we can look at and say, is it working or is it not? And each one of those records is important to be accurate so that when we get it all the way up to this big giant pile of data that we're digging around in, we can trust it. We can know that all of you are putting in the best information that you can so that all of the citizens in the country can get the best care that they can. So I could go on for days about it. I think that our data is so powerful, and I'm over the moon happy that other people are starting to pay attention to it.
What you're saying is the data we're producing is useful?
Yeah, I mean,
you're saying
really
it matters?
It really matters.
And so what's really cool is you've introduced me to biospatial, which is an application that allows us to really dive into MyEMS's data essentially. And what we're learning is we have access to knowing stuff that we didn't think we'd know. It's revealing information to these EMS systems before they even recognize it as a problem. That's huge.
Yeah,
that allows us to prevent the thing from happening. And that's kind of the point. Health care, not sick care.
Emily, so what I hear you saying is that by us, the EMS providers, providing this information up to the state, at my level as an EMS provider and an EMS coordinator, I might not have enough data just in my agency to be able to look at and see trends. But by all of the agencies providing the state with data through MyEMSIS and then NEMSIS, all of that data provides the whole system with answers.
Right. For it to be relevant data, you kind of hit the nail on the head, John. It can't be 5 records. If you are looking at 5 records, if 2 things were wrong, then you're at like 60%. Well, dang, like that looks really bad, but you're only looking at 5 records. And so that's not actually a big enough pot of things. So when you roll it up, if it's 5 things in your county and there are 83 counties in the state of Michigan, well, now we're cooking with gas, right? Because now we're in the hundreds of records. And if we roll those hundreds of records to the 50 states, then we're looking at thousands of records. And so now if 2 things happen that were adverse, now we know those are anecdotes because they were the only 2 out of thousands versus it was 40%. So yeah, it's really important that we can roll all of that up.
I think that it's also important that we note that historically speaking, at the state and MCA levels, we haven't necessarily shared this information with our EMS providers or shown them how we are using it, and they may not value it. And that's partially our fault at this level. And I think that we need to make a more concerted effort to show our field providers how we are utilizing their data. For example, the maps and curves that you were showing for COVID due to that syndrome tracking. It's very valuable information.
Yeah, you're right. It's totally on us. I haven't been in the office for that long. And honestly, we haven't been in this data system that long. But now that we know the potential and we have these tools, it is really important that we share so people understand. And I will talk to anybody who wants to call and ask or send me an email and ask a question or talk about it, because I, as a paramedic, because I did it for a long time, this is really exciting because finally someone is actually listening to us. So this is our chance to show like what we do really matters. And we can't show that if we don't have the data. Okay, off my soapbox again.
No, I love that because it's a great segue into what we're going to talk about now. So the data, and let me just remind you, my buddy Danny Flanders, you might be listening, Danny. Danny says data drives decisions. Now, Danny's a CRNA. He's also a pilot, firefighter, paramedic. He makes a lot of decisions. So I'm going to go ahead and say that that's a pretty good piece of advice for somebody like that. Now, that data for EMS ends up into MyEMSIS and then into NEMSIS. So it's important for EMS providers listening to understand that, yeah, data is really important, but you got to have a foundation of where does this data go and why does this data need to go there from a foundational level. So, Emily Bergquist, what is NEMSIS and MyEMSIS? Why should I care?
Well, we lovingly call it Nemesis sometimes, but I digress. So the National EMS Information System and the Michigan EMS Information System are NEMSIS and MyEMSIS. So the NEMSIS, the National EMS Information System, is pretty much the largest pot of EMS data that you're going to get. Most states in the country, I cannot say all because I don't actually know that by fact, import their information into that repository. And if you haven't had a chance, there's a really actually only 2-minute long video at ems.gov about NEMSIS and the data utilization. So feel free to go over there and see it because it's pretty neat. It is a national repository, and so many people get data out of that repository. De-identified data, obviously, but there are people who study medications and disease processes and pediatric patients, etc., that are all pulling information out of that national system so that they can have those large buckets to actually see relevance in things that are done. People who design cars, they pull a whole bunch of things to say, like Ford Motor Company will go and say, I want to see, they'll do a request and they want to see all of the records that people documented that involved a Ford, for example. So it's just an amazing, huge pot of data that is being utilized to make everyone's life better. It's not just clinical treatment. It's also like vehicle design and traffic safety and all of those things that you would not think necessarily when you're clickety-clackety on your tough book or you're poking the buttons on the iPad. You wouldn't necessarily think about that, but each one of those records is like a tiny Lego in the castle that is NEMSIS. And so many things are being drawn from that. So that's the National EMS Information System. And then obviously Michigan's is the same, but for Michigan's system. And so it's all stuff that's very specific to us. But we utilize that a lot for protocol evaluation. So we put a protocol in place, we educate about it, or we try, and then we evaluate. Are people doing it? You know, we gave this medication, put it in protocols. Is anybody even using it? One, and if they are using it, is it being used correctly? And if they are using it and it's being used correctly, are the patients having a positive outcome? So we use that Michigan system for that, but there are other people that also play around in that. The opioid people, they're the ones who probably use it the most to monitor trends with overdoses. We're actually exploring a project that is pretty cool that will link our stuff with the vital records. So we would be able to link EMS records with death records, not obviously directly, but like how often, for example, is someone refuse EMS care and then end up in the vital records. So it's a whole bunch of different things that can interface together if it's there to be interfaced with. So that's Michigan's information system.
Fantastic. So if data drives decisions, the data repositories have a huge impact on the practice of an EMS provider, right?
Yeah.
So we talk about the fact that data drives and shapes our protocols. It validates our performances. It identifies whether a treatment or a decision we're doing in protocol works. It really can help us determine the effectiveness of treatments, procedures, and total processes. The other thing it can do is resource allocation. It provides data for a need. Help me understand that better.
So for agencies specifically, and really MCAs too, this data can show what you're kind of doing for your area so that you can show people what you need. For example, we'll use it for like coronavirus, for example. You need more PPE because we're in coronavirus and we're having this pandemic, and your people are like, I don't understand why you would possibly need that much more. You can actually show them, look, we have all of these records that have all of these signs and symptoms, and we need to have all of this PPE to support that. And if we continue on the current trajectory that we're on, this is how much we're going to need in 2 weeks. This is how much we're going to need in a month. So for your communities, for your counties, for your cities, wherever you're working, you can look at the specific needs that you have and then try to meet those needs. And you can actually show it. It's no longer, we're just telling you. Trust me, we're running 100 calls a day. You can say, look, here are my 100 calls. This is the distribution of the types of calls that we're having. We're having 90 car accidents out of those 100 calls in this general area. We need to do something about that. So you can get resources kind of allocated to you specific to what you actually need based on the data.
That data also reveals a need that may be filled by grant opportunities or foundations that will fill that. I mean, there's so many things you can do with assets that currently exist as long as you can articulate the need. And if you don't have data to support your need, you don't have a problem.
Right. Response times is a thing. Like you can look at it and say, look, our response times have been increasing because we're running these calls and our people are further away, or maybe we need to move a station, or maybe we need to add another station, or, we need more people, or we need more of this type of vehicle, or we're running short on these supplies, whatever it is, like those things, there's data in that system to prove or disprove. That's a funny thing because sometimes it's used to disprove. So someone will say, this hospital always makes us wait 25 minutes. And you can actually look. You can look and see how long your crews are waiting per hospital. That is in the system also. So you can say, waited one time 25 minutes, but their average is like 7. So, you're applying an anecdote on the whole. So use it.
It's an honest look, right? That's the whole idea. It's honest.
That's the idea. If you put it in correctly,
let's get rid of opinion. The numbers don't care. I want to know what actually happened so that we can make it better for everybody. Okay, let's talk about some examples about how data can help shape the future of EMS.
What community paramedicine is, if you've seen the Venn diagram about EMS, where it's public health, healthcare, and public safety, and in the little middle between those 3 circles is where EMS is, community paramedic kind of delves further into the public health and healthcare system side. Community paramedics are leveraging all of the things that EMS does and knows, their trust with the community, their clinical experience, I'm going to call it the sixth sense for patients who are sick or not sick. And it's leveraging that in order to fill gaps inside, honestly, society as a whole, but specifically the healthcare system. Some of the programs are hospital system driven and some of them are agency driven. And it just kind of depends on what your community needs. But tying back to the data, community paramedicine isn't for every area. It's not for every community. And you can utilize your data to figure out, do you actually need it? Is it something that you should be exploring? Or is it maybe you don't have a huge gap that EMS could really fill? So you do a community analysis and you look at your runs and you find that you're having a whole lot of falls, which honestly, our whole EMS system has a whole lot of falls. Falls are a real thing and it happens a lot of places. But you see, for example, that you're having a whole lot of falls in very specific areas. You can utilize that to say, hey, a community paramedic can go in and say, what? Because honestly, even people who are not community paramedics, how many times have you gone into a house and been like, that is the next call, is that furry rug and you and your walker, because this is a bad idea, or your cat, or whatever the case may be. You can leverage the fact that people trust paramedics to come in and they listen to us. When we say, ma'am, this is really not a very safe environment for you to have 60 feet of nasal oxygen tubing that's wrapped around a chair 3 times. Let's work together to figure out what the better thing is. you can use your data to figure out if you even do need community paramedicine, if it might be valuable to you, and then also implementing it, you can track and see if it helps. That's kind of the tie with community paramedic and data.
What you're saying is community paramedicine is really tied into community risk reduction, which is discussed a great deal on the fire side with fire prevention. And this is actually EMS injury prevention.
Yeah, and honestly, we don't have a whole lot of fire-based community paramedic programs in the state of Michigan right now, but in other states, they really do, because that adds a whole other element. Because you have these firefighter paramedics who have clinical knowledge, then they learn like the public health and social work pieces. That's the best description of what community paramedic school is about. You go in and you learn these other pieces, and you have like the fire safety pieces. I mean, it's a really great combination of things for you to be able to go into these houses and say, your regular paramedics are like, we were in this house and it was not safe. And you can leverage that.
You mentioned the community paramedic training or community paramedic school. From my understanding, there's a push to standardize that within the state. Is this data affecting that process?
Yes, we have utilized what the different community paramedics are doing and how successful they are at different things to tailor the educational objectives. And that's a whole other, we haven't even really talked about that, but it does tie back into educational initiatives too, where we can say, okay, this is clearly working, this isn't working, this is something they know how to do, this is not something they know how to do. And then we can utilize that data to drive objectives for education as well. It's like this whole other arena of data.
How about another program? So community paramedicine is a way for risk reduction in your area. But what about this alternate transport destinations, also known as ET3? Give us some background on that and how the data is kind of shaping maybe some things of the future for EMS.
This is part of, I think, the stretching of EMS. This is the first time we've had an opportunity for payment for something other than driving from point A to point B. So ET3 is a federal initiative where the Centers for Medicare and Medicaid Services have identified specific agencies and areas, depending on where you are, to allow for EMS to act in a different way and take patients to places other than the emergency department. And it all got a little bit delayed, but in essence, what this is going to allow is we're going to be able to see, you go in for a low acuity patient and you do an assessment, and you touch base with them and you touch base with the hospital, and then you take them to an urgent care or to their primary care physician's office, or in some cases a wound care clinic, to have targeted resources that are appropriate for the acuity and the condition of the patient. And so we're going to be able to watch that and see if it's successful, and then follow up to make sure that it's being done safely. And if that can happen for EMS, it's going to be a really huge turning point where EMS will be starting to be paid for clinical things, right? Making the appropriate assessment, treating them appropriately, and getting them to the appropriate resource, as opposed to just getting paid for driving the patient from point A to point B, because that's the way that it is right now. That data is going to allow us to show, I have complete faith that it's going to show that EMS can clinically understand what is the appropriate place for the patient to be and make sure they're treated that way, as opposed to this everybody goes to the emergency department situation.
Will my MSIS data be used to evaluate that program in any way?
We are hoping that through my MSIS and Hospital Hub, which is like my MSIS hospital bridge, that we're going to be able to do some linkages for these patients. We will be tracking patients who go to places that are not hospitals. That makes sense, so that we can see what is happening, what kinds of patients they are. And then we can also see, are we going back there? Does EMS go back to the same place again in 6 hours, and then they have to take them to the hospital anyway? And then if the patients are in the hospital, is there an outcome that we can link together? So we're hoping it's going to be a stretch for the MyMSIS data, mostly because our data has been so disparate or separated. We don't have a lot of hospitals backfilling outcome information right now, but that is a real push that's happening for a few different reasons. And if we can really get that in where people are actually inputting from the hospital side or the physician side back, it will be able to really show positive things.
So is it safe to say programs like community paramedicine and ET3, which offer alternate transport destinations, are really only successful if we have data repositories to facilitate them in order to collect that information and identify if they're even effective?
Yeah. I mean, otherwise one bad thing happens and the whole thing goes out the window. Again, with the anecdote versus aggregate, you have to have a bucket.
Absolutely. You gotta have a measuring stick. And we all have to agree that a foot is a foot. There's no difference based on your region. It all has to be the same. But I do want to say something closing out of community paramedicine and alternate transport destinations. Those programs are not being enforced on any agencies or regions, right?
Oh,
so
yeah.
any providers listening to this is not any type of, hey, this is coming, you're going to have to do that. These are simply programs that some areas around Michigan and the country are utilizing that depend on data. There are many other programs that depend on data. Successful ones in Oakland County include our basic EMT epinephrine study, which relied on our EPCR data, our current stroke systems of care special study, Narcan, ketamine. All of this is dependent on the data. Data also does this other thing with cost analysis of patient care. I hate talking about money and people in their healthcare. It drives me nuts. However, data supports and justifies our existence in a logistical facilitation sense, and we're not free. There are many volunteer agencies out there. Even the tools they use, those aren't free. So, can you guys kind of help me understand how data is used for that cost analysis of patient care?
Many of us in EMS are upwardly mobile and looking to become administrators at some point or supervisors. And it starts with your PCRs today. Your PCRs today are going to set up your reimbursement when you're the one trying to figure out the budget.
It's real, and nobody likes to talk about reimbursement and money. Like, I had a really hard time with it as a paramedic as well. But the fact of the matter is that we need to get paid what we're worth, because otherwise we won't be here.
What's nice about that is nobody's asking you to do anything different to get your agency paid. If you're doing it for all the reasons to just have a complete, thorough report which expresses the entire patient encounter, your transport, everything, you're covering all your bases.
I think that it's hard for people to view healthcare as a business, particularly with the amount of time that we spend focusing on patient-centered care and patient-centered policies and focusing on safety. However, in the long run, we all need to remember that the calls that get written off due to poor documentation, that may be the equipment upgrade that you were hoping for that will allow you to provide better patient care. It all comes full circle in the end.
So as we round out this discussion, Emily Berquist, can you help us list and describe the steps an EMS provider can take to assure they are complying with all NEMSIS and MyEMSIS standards so that we can enjoy the benefits of all of the things we talked about today?
Well, I think the first thing, and anytime, I think every podcast or training I've been on with you, Jeff, I've said you need to know your protocols. There's documentation ones too. Yay! You need to be able to know what you're supposed to do. And that is now more than before, better laid out for you inside that protocol. So there are times that you have to fill out a PCR. There are specific things that you need to have in your PCR, like, vital signs, the patient's chief complaint, what you thought was wrong with them, et cetera, et cetera. Those things have to be in your PCR, and you need to do it when you arrive on a scene. You need to do it when you can't find a patient. You need to do it when you do a refusal. Like, you have to have a PCR for those things. You need to document that those things have happened. And they need to be completed, and they need to be completed in a timely fashion. And I think the timeliness is variable for different types of patients. If you take a patient to the hospital would like to have that report, especially for time-sensitive emergencies, strokes and STEMIs and trauma patients. Like, those reports are something that they rely pretty significantly on. But anytime you take a patient or you touch a patient, the new protocol is anything has to be in the system, transports or invasive procedures within 24 hours. Where I worked, we weren't allowed to go home until our reports were done. So this is always one that I'm like, yeah, you really need to do it. and you need to do it in a timely fashion. It's not 2 weeks from now, because honestly, do you actually remember the circumstance of that call 2 weeks from now? You don't. You don't. You should have put it in when it's still fresh in your head. In standardization, make sure that you are clear on what all of the things that are being asked inside that PCR. Let me just tell you that the provider's primary impression, I'm just going to throw this one out there, it means what you think is mostly wrong. It doesn't mean what you thought was wrong the first second you laid eyes on the patient. And that actually was a confusion point. Your provider's primary impression is what you, as a clinician, believe was the most significant thing wrong with the patient. So if the patient is complaining of abdominal pain, but they're actually having a STEMI, your primary impression should probably not be abdominal pain. That's their chief complaint. That's a different thing. So make sure you're familiar with what those data points actually are asking inside your PCR. And if you're not clear on that, ask your QI person, ask your supervisor, ask me. That's fine. We'll tell you. Johnny and Kevin in our office will gladly answer your questions about what that means. So make sure you know what those are, because then when we're documenting it, we know that we're all documenting the same thing. And then the last thing I'm going to say about it is that you should be open to feedback. And honestly, take some time when you're looking at runs. If you have a moment, look at each other's runs. There are things that I learned from other providers that are like, I documented it in a particular way for a long time because I learned it from someone else, because we do not a great job in school of learning how to document. Look at other people's, listen to what people are saying. No one is going to critique your documentation for no reason or because they're mad. When someone's critiquing documentation, they've taken time to review. There's a reason for it, and they're going to share that with you. It's not personal. You're not a failure. You're a human, and everybody can learn and be better. So be open to the feedback that your folks around you, your MCA, your QI soup, whoever it is going to give you.
From the agency perspective, there's a slightly different angle. Now, Emily Baker, you do CQI for an ALS agency that provides 911. It provides interfacility transport. So you have this huge spectrum of EPCRs that you've always been reviewing for years and years. So can you please help us list and describe steps a life support agency can take to assure that they are complying with all NEMSIS and MyEMSIS standards so that their EMS providers and patients experience all those benefits of downstream?
Well, one of the most important things that every EMS agency should have is a QA or QI, depending on their preference for language, program, and a individual or committee that is assigned responsibility for that. It can be set up in many different ways depending on the needs of your agency and the resources that you have available. There is not one right way to run a QI program. Most that I'm familiar with choose to routinely review documentation and runs based on specific criteria, and then also use random generation if they use a software that allows that. And of course, if there is a concern that is brought up, that report is reviewed as well. It is unfortunate that there are some places that only review reports when there is a concern related to patient care or safety. And I truly believe that everyone should consider how many concerns are being overlooked, if that's the case and that's how they're doing it. But when reviewing these reports, most people think about looking at the quality of care, protocol compliance, policy or procedure compliance, which are hugely important elements. That is one of the primary goals. You're looking at all of these aspects of the run and determining if there were any deficits and how you can educate and improve, because that's always the goal. The goal is improvement. So it should be education driven. But when you're doing that run review, you also need to be looking at the related data standards. When you're reviewing the vital signs to make sure they were done with appropriate frequency, also make sure that the data entry in the pain scale is between 0 and 10 and isn't 14. While the patient may have stated 14, the MyEMSIS program can only accept values between 0 and 10. So we need to review these to make sure that things are being documented appropriately at the same time. And that sounds very intimidating because it's a lot. There's a lot of details, but it really does become easy over time. It becomes much more intuitive And it's important to spend the time and dedicate the personnel to learning those details so that it can become a more efficient program. If you find issues through this program, whether they are protocol, quality of care, or data related, it's then very important to be sharing that information with your EMS providers and providing education to them. Not only asking them to review the protocol, but making them aware that for this particular portion of your PCR, it needs to be completed in this manner, like the provider impression example that Emily gave. Issues like that can be prevented very easily through communication. And then when it comes to the point of actually making sure your data gets into the programs that it is required to be in, a lot of agencies are very lucky in this fact because most softwares do allow an automatic upload. When the report is completed, it goes into the queue, and depending on the frequency of upload that is set in their software, it is automatically exported. But that needs to be checked. Somebody at your agency needs to be responsible for making sure that that upload is functioning continuously. Those softwares will also provide flags if there are errors, and that may be that the entire export did not make its way across the magical computer data bridge, or it may be that this particular record was not able to be exported because it did not meet validation standards, meaning that something in that record is entered wrong. Again, very luckily in those programs, they will tell you what it is, which field it is. If you don't know what that means, find out, reach out to the state office, investigate that. It may be a standard documentation practice that's happening across your agency that is technically incorrect, that could be changed with a little education or one simple rule change within your software. For agencies that manually enter their records into MyEMSIS using that as their documentation software, you need to create an audit system to ensure that those are checked. And once again, I personally see the most important element of that being assigning responsibility to an individual or a committee.
Thank you. I think it's also important to recognize there that the individual, the committee is probably dependent on the number of runs you go on, because if you go on 10,000 runs every 3 months, that's a lot. You're going to need like a team of teams to go through that information. And there are agencies that go on a heck of a lot of runs, and then some maybe go on 1,000 a year. So it's different.
It's very specific to the individual life support agency, and everyone needs to evaluate their needs. But this is where that data, such as your run volume, can help you to evaluate what your needs are and make appropriate decisions. And just like Emily Berquist has said, she will gladly talk to anybody about the data systems. I am more than happy to talk with anybody or answer any questions about quality improvement programs and how their agency can develop or grow those programs. I'm currently a supervisor on that side. It is a part-time position for me at this point in time, but previously I was the coordinator for a whole program for a life support agency. So I'm always happy to be a resource as well.
That is all for the show today, everyone. Thank you for listening. Thank you to all of our guests for coming on the show and spreading your knowledge. If you want to get a hold of any of today's guests, you can find their contact information in the episode description. Also, I'd like to take a quick moment to recognize the other EMS providers that were directly involved in the development of the content presented in this episode. Thank you to Allison Bellitti, Luke Bowen, Justin Allen, Yehuda Kranzer, Chris Watts, Matt Prang, and Dan Miller for your time and participation in the development of today's content. Your time is truly appreciated. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review, because it really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.